the bleeding disorders, and today's topic is disseminated intravascular coagulation. By name itself, there are three things. One is disseminated, means widespread or involving many parts of the body. Intravascular means in the vessel. Coagulation means formation of thrombi. So by name itself, it says that there will be widespread thrombi formation in the circulation. Okay, so it is an acute, subacute, or chronic thrombohemorrhagic disorder. So it has two things. One is thrombosis, going on thrombosis. Next is hemorrhage, and either they might be oscillating between the thrombotic and the hemorrhagic phase, or the thrombosis and the hemorrhagic disorder might be going on side by side in different organs, and it is characterized by excessive activation of the coagulation and formation of the thrombi in the microvasculature. And later on, due to the formation of these thrombi, there will be activation of the fibrinolytic system, leading to hemorrhage. Okay, so it is a acute, subacute, or chronic thrombohemorrhagic disorder characterized by excessive activation of the coagulation and formation of thrombi in the microvasculature. So this is the definition of DIC. DIC occurs as a secondary complication of many disorders, which we will be knowing later on, and it is sometimes localized to a specific organ or tissue. And as a consequence of this thrombotic diathesis, there will be consumption of the platelets, fibrin, and coagulation factors. So there is a widespread or disseminated thrombosis. So due to this widespread thrombosis, there will be consumption of the platelets, the fibrin, and all the coagulation factors that is present in the plasma. And ultimately, there will be, due to the presence of these fibrin thrombi, there will be activation of the fibrinolysis, because body knows that now coagulation is being taken place in an abnormal location at an abnormal time. So there should always be a check between a procoagulant and a anticoagulant factor. So that is always in a balance. Whenever there is a trauma, then there should be coagulation in just the area of the injury in the right time, just after the injury. It should start and it should be limited to that area. But here, in the area where there are intact endothelial lining also, there will be activation of the endothelial cells, and many things will go on, which we'll be talking in this lecture, which will lead to formation of the microthrombi in the circulation, mostly in the microcirculation. Okay, so secondarily there will be activation of the fibrinolytic system, leading to formation of the fibrin degradation products. So this is not a disease by itself, but it is a complication of many other disorders. So ultimately, they present with signs and symptoms relating to the tissue hypoxia and infarction, which is caused by the microthrombi. For example, kidney. So whenever the microvasculature of the kidney is studded with the microthrombi, then the kidney won't be able to do its function, and it will get infarcted, and there will be due to the tissue hypoxia and the blockade of the microcirculation, and there will be hemorrhage. So one is tissue hypoxia and infarction, and the next is hemorrhage. Due to the depletion of the factors required for hemostasis, and there will be activation of the fibrinolytic mechanisms, or both. Okay, initially starts as a widespread formation of the thrombi. Widespread coagulation will be there. Later on, there will be consumption of the coagulation factors and the platelets, and secondary activation of the fibrinolytic system. So it will lead to hemorrhage. So that means they will present with, ultimately, there in each and every organ which is involved by the DIC, the signs and symptoms will be relating to the tissue hypoxia and infarction, which is caused by the microthrombi, and hemorrhage due to the depletion of the platelets and all the coagulation factors that is required for the formation of the platelet plug. And secondarily, there will be activation of the fibrinolysis, or both can also be the cause. Now let's go to the etiopathogenesis of DIC. Like we already discussed, DIC is not a primary disease, but it is an complication of various clinical conditions. It is an acquired coagulopathy. And this DIC could result from, one is unwanted pathological activation of coagulation. Unwanted. This should be unwanted. This is untimely, unchecked activation of the coagulation system, and impairment of the clot inhibiting mechanism. So in our body, due to many causes, okay, these causes we'll be talking later on subsequently in this lecture, there will be impairment of the clot inhibiting mechanisms. In hemostasis, we had talked that in a normal endothelial lined vessel, there should not be formation of the clot, or the coagulation should not be there. But that is impaired in case of DIC due to the various primary diseases that occur. So for knowing DIC, I again would like to take you back to the normal hemostasis with a review of normal clotting and clot removal process. Just briefly, the clotting in vivo is initiated by exposure to the tissue factor. If you remember the right side of the clotting cascade, okay, the right side, there is the extrinsic pathway leading to the common pathway. So in the extrinsic pathway, there is activation of the factor 7 and is initiated by the exposure of the tissue factor. And this tissue factor, factor 7 activated complex, it activates the factor 9, which will in turn activate the factor 10. And this activation of factor 10 will lead to generation of the thrombin. And at the sites where there is trauma, or where the endothelium is disrupted, at that area only, the thrombin will convert the fibrinogen to the fibrin. It will stimulate the fibrin cross-linking, and it will inhibit the fibrinolysis and also activates the platelets. Is this clear? Is this clear till now?
Yes, sir.
Okay. That means now to know about DIC, we should know about the normal hemostatic mechanism, either extrinsic or intrinsic pathway. Okay, extrinsic starts with the activation of factor 7, whereas intrinsic pathway starts with the factor 12 activation, and they both lead to, or they both will culminate in common pathways where there should be activation of factor 10, and this will lead to formation of the thrombin from prothrombin. So whenever there is a injury or wherever there is a disruption of the endothelium, at that area where the primary platelet plug is already been made, there the thrombin will help in formation of the fibrin from fibrinogen, and it will cross-link the fibrin which is made there by the help of the factor 13. Okay, and at the area of the injury, there should not be fibrinolysis. So fibrinolysis is inhibited. Otherwise, there will be dissolution of the clot. So there should not be dissolution of the clot. But actually, if there is any other normal area where there is formation of the clot where it is not needed, then fibrinolysis will start, and there will not, the formation of the clot will be inhibited, or not inhibited, but already formed clot will be dissoluted. Okay. So to prevent clotting at the normal areas, this we have already talked about, this process must be limited at the site of the injury. And this is done by the thrombomodulin. Okay. In the area of the normal endothelial lining, the thrombomodulin complex, which activates the protein C, it inhibits the factor 5 and factor 8. Okay. It inhibits the factor 5 and factor 8 so that there won't be formation of the clot. One thing. And if already a clot has been made, then there will be fibrinolysis by plasmin. From plasminogen, plasmin will be made, and there will be fibrinolysis with the help of this plasmin. So here you can see one is thrombomodulin. If there is thrombin which is freely flowing in the blood, okay, if there is an intact endothelium, then it will be then the thrombomodulin will activate protein C and inactivate the factor 5 and factor 8 activated. So there will be no formation of thrombus at this area. And if there is formation of the clot, this should be limited to the area of the injury. If it is not made at the area of the injury, then there should be fibrinolysis. And there should be fibrinolysis if there is clot. And this free plasmin, which is bound with the alpha-2 antiplasmin. This alpha-2 antiplasmin is inhibiting the free plasmin. But when it sees there is a clot formation in an or area where it is not needed, then it will be freed. Then this plasmin will come to the clot area, and then it will lyse the fibrin. Then there will be formation of these fibrin degradation products. Now the triggering mechanism of DIC. We come back to DIC. Now we know that how a normal hemostatic mechanism is maintained, and what happens when a clot is made, or clot has developed in a abnormal area where there should not be a clot. There should be a fibrinolysis by the fibrinolytic system. Now, what are the triggering mechanisms for DIC? So, first one is release of tissue factor or other procoagulants into the circulation. There will be release of tissue factor because this is the potent activator of the extrinsic pathway of coagulation, or other procoagulants into the circulation due to any diseases. This is not due to any localized trauma, but this can be due to either massive trauma or any other primary diseases, which we'll talk here. And there will be widespread injury of the endothelial cells. So these two things are the major triggering mechanisms for the disseminated intravascular coagulation. One is release of any procoagulants like tissue factor or any other procoagulants. The second thing is widespread injury and activation of the endothelial cells. So here you can see this is the initiation of the DIC, and what happens, what is the outcome of the DIC. Okay, there will be activation of coagulation factors and the platelets. First the platelets will be activated and then the coagulation factors, and there will be formation of microthrombi in the circulation, in many parts of the circulation, and this will lead to the end organ damage. And there will be depletion of the coagulation factors and platelet due to their consumption, because these microthrombi are formed at many areas of the body. So there will be bleeding diathesis, and at the same time fibrinolysis will also start. So apart from this depletion of the coagulation factors and the platelets due to consumption in the microthrombi formation, there will be activation of the fibrinolysis. So there will be bleeding diathesis. So one is there will be infarction, okay, hypoxia, and infarctive changes will be present in many end organs like kidney, the brain, lung, liver, and many other organs. But along with that, due to the depletion of the coagulation factors and the platelets and the secondary activation of the fibrinolytic system, there will be bleeding. And the procoagulants, such as tissue factor, can be derived from a variety of sources. Now, what are the causes of DIC? Now we talk that for DIC to happen, there should be release of procoagulant in the circulation, and there should be activation of the endothelial cells or injury to the endothelial cells. These two things are the most important triggering factors for the DIC. But what causes those two things? One is sepsis or severe infections. Then the major trauma with cross injury. By here, you can know that whenever there is a major trauma or a polytrauma with cross injury, automatically there will be release of the tissue factor. Whereas in sepsis or severe infections, there can be endothelial activation or endothelial injury can be there. In obstetric complications or conditions, amniotic fluid embolism, abruptio placentae, septic abortion, eclampsia, intrauterine retention of the dead fetus. So these are the obstetric conditions. Okay. For now, do not ask me what abruptio placentae is. It is a complication of pregnancy in the 3rd trimester. Septic abortion, you know, whenever there is a termination of the pregnancy, but with septic features, that is septic abortion. Eclampsia will be there, and then intrauterine retention of the dead fetus. So with obstetric complications also, there can be triggering of the DIC, and many malignancies like disseminated solid cancers, cancers of any site, including acute promyelocytic leukemia. And the another one is snake bite or snake envenomation. That can also lead to DIC. So we had talked about septic shock, right? In the previous block, we had talked about septic shock in first semester. It is that's why it is a very, very important chapter. And during that, we talked a lot about DIC. Everywhere DIC, we talked about association of the sepsis or septic shock with DIC. So now I think it should be clear to you in your mind why DIC is important in septic shock and why we should always be worrying about formation or DIC in sepsis and septic shock. Okay. Roll number 21. Roll number 21.
Yes, sir.
Can you please
Yes,
till now whatever we have told about DIC and its causation, can you please elaborate?
DIC, disseminated intravascular coagulation, is an acute, subacute, or chronic thrombohemorrhagic disorder characterized by excessive activation of coagulation and the formation of thrombi in the microvasculature.
Very good. What are the things that will trigger DIC?
They are the causes of DIC are severe infection.
Okay. But what are the two triggering factors? These are the causes, but we have talked about two triggering factors. These all things what we have talked causes of DIC.
Tissue hypoxia and hemorrhage. Tissue hypoxia and hemorrhage.
Those are the outcome. Those are the outcome, or those are the manifestation of DIC. Okay, one is release of procoagulant. One is endothelial injury, widespread endothelial injury. Okay.
Yes, sir.
Okay, what's your name?
Sachin Nimire.
Sachin. Okay, thank you, Sachin. Good. Roll number 49.
Yes, sir.
So who is speaking?
Sujata.
Okay, Sujata. Sujata, we have talked about DIC. Can you just review the normal hemostatic mechanism which will be disrupted in case of DIC? So how will be the normal hemostatic process going on?
So when there is tissue injury, there is a failure of the subendothelial matrix,
Okay.
which contains collagen and the von Willebrand factor,
Very good.
and there is a platelet having receptors of glycoprotein phosphate.
Okay, 1B.
1B, which is binded to one Willebrand factor and the collagen,
Okay.
which leads to the conformational change in the platelets
Okay.
and the release of the granules.
Okay.
Due to the release of the granules, there is a release of the thromboxane A2, ADP,
Okay.
which leads to the elevation of the platelets.
Very good.
And from the injured endothelial injury, there is the release of the tissue factor, which
Okay.
leads to the activation of the intensive pathway.
Okay. Release of the tissue factor.
Yes, sir.
Okay.
and there will be the activation of the coagulation factor. So this is the activation of the fibrinogen to fibrin, which
Okay.
binds the platelets by the receptor GCCA.
Okay. 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 Thank you, Sujata. Thank you. Very good. Okay. Roll number 62. Roll number 62. Absent. Roll number 63. Okay. Navin Bandari. Navin Bandari. Navin, are you there? Okay. Nilisa Bandari.
Yes, sir.
Are you hearing me properly?
Yes, sir.
Okay. Sujata has very nicely talked about the formation of the primary platelet plug and the secondary hemostatic plug, right? Nilisa?
Yes, sir.
Okay, she talked about the formation of the primary platelet plug and the secondary platelet plug. Now, how is that formation of that clot is limited to the area of the injury? What is the mechanism?
There is presence of tissue plasminogen activator.
Okay, very good. You are doing good.
Which creates the fibrin.
One is that there will be. Can you relate this picture? You talked about the tissue plasminogen activator, right? Which activates fibrinolysis.
Thrombomodulin activates protein C.
Okay, very good, very good.
Activate factor 5 and factor
Okay,
8.
okay, okay. These are the factors which inhibit the thrombosis in the normal area. Okay, one is the normal intact endothelium. Also, is there will not be activation, adhesion, and aggregation and activation of the platelets won't be there, and prostacyclin, nitric oxide, all will be there. Yes. And there will be tissue plasminogen activator, heparin-like molecules will be there, and then tissue factor pathway inhibitor will be there, and thrombomodulin will be there. So you should know all these things.
Yes, sir.
Okay. Okay, thank you. So we'll go to causes of DIC. This we have already finished. Okay. Sepsis or severe infections, major trauma with cross injury, obstetric conditions like amniotic fluid embolism, abruptio placentae, septic abortions, eclampsia, and intrauterine retention of the dead fetus. And malignancy like disseminated any solid cancers or acute in leukemia, acute promyelocytic leukemia is the most common. And then snake envenomation. So these are the major causes of DIC. So there can be other causes which might lead to DIC and which are not stated here. Okay. So let's go through the pathophysiology of DIC. Here you can see we had told that release of tissue factor or a procoagulant is a triggering factor for the causation of the DIC. So here you can see massive tissue destruction, like in case of any polytrauma or any crossing injury, okay, or any burn injury, there will be a massive tissue destruction. Also in products of conception, if there is a dead intrauterine fetus, or in case of sepsis, or in sepsis also there will be endothelial injury. But if there is any other factor leading to endothelial injury, so it will ultimately lead to release of the tissue factor. But endothelial injury alone also can lead to platelet aggregation and formation of the platelet plug. So due to this release of tissue factor, there will be widespread microvascular thrombosis will be there, which will lead to vascular occlusion. Due to this vascular occlusion, whatever blood the patient has in the is flowing in the vessels, now there will be microangiopathic hemolytic anemia. Now there will be thrombosis, widespread thrombosis will be there. So the RBCs has to undergo extreme deformation for traveling in the blood vessel. So there will be microangiopathic hemolytic anemia, and there will be vascular occlusion leading to microangiopathic hemolytic anemia, along with ischemic tissue damage in the end organs, like for example kidney. Apart from that, there will be consumption of the clotting factors and the platelets, which will lead to bleed. And secondarily, this widespread microvascular thrombosis will lead to activation of the plasmin, leading to one is fibrinolysis and the second is proteolysis of the clotting factors, which will ultimately lead to again to bleeding. This fibrinolysis, after the fibrinolysis, there will be fibrin split products or fibrin degradation products will be there, FDPs. These FDPs will inhibit the thrombin, inhibit the platelet aggregation and fibrin polymerization. So whatever is in the DIC, it is within this flowchart. You should know this flowchart. And whenever it comes, it is asked in the exam, you have to write a bit in the paragraph about pathophysiology and make this flowchart. Do not only make this flowchart, but make this flowchart, which is compulsory if a pathophysiology of DIC is asked, and then write something about this, like the triggering factors is number one is release of a procoagulant like tissue factor. Second is activation or endothelial injury. And then what happens? Then there will be widespread microvascular thrombosis leading to vascular occlusion and ischemic tissue damage, along with microangiopathic hemolytic anemia. And then there will be consumption of the clotting factors and the platelets because of this widespread microvascular thrombosis. Okay, if this thrombosis was localized and present in a single area, then there won't be this consumption of the much of these clotting factors and platelets, and it would be present in large number in the circulation. But due to this widespread microvascular thrombosis, there is shortage of clotting factors and the platelets. That's why if you see here, now what we see is we can correlate this with the laboratory feature. Due to the consumption of the clotting factors and the platelets, and there will be bleeding time will be increased, PT will be increased, and APTT will be increased, and thrombin time TT will also be increased. And fibrinolysis, due to this fibrinolysis in DIC, we can detect fibrin degradation products, FDPs. So if FDPs is increased, then that also is an indicator of DIC. So this we have already talked about. We will just go through it. Endothelial injury initiates DIC in several ways. The injuries either direct injury with massive tissue destruction or sepsis, okay, leading to endothelial cell necrosis, will expose the endothelial matrix, and there will be activation of the platelets and the coagulation pathways. And DIC occurring with sepsis, here the tumor necrosis factor alpha, TNF, is the mediator of the endothelial injury. If it is sepsis, then TNF is the mediator of this endothelial injury. So here we know that massive tissue destruction, directly it release the tissue factor by injuring the endothelium. But whereas in sepsis, there will be release of the TNF, and it will be the factor or the mediator which will lead to endothelial injury. This TNF induces endothelial cells to express tissue factor on their cells surfaces and decrease the expression of the thrombomodulin. Thrombomodulin checks the procoagulant state, but this is decreased, so there will be a procoagulant state. And the TNF, it also upregulates the expression of the adhesion molecules on the endothelial cells and promotes the adhesion of the leukocytes. Therefore, there will be it will damage the endothelial cells by releasing the reactive oxygen species and preformed proteases. And there can be widespread endothelial injury by either deposition of the antigen-antibody complexes like in SLE, or in heat stroke, burns, or microorganisms. In the burns, there can be by bone itself also, there will be widespread endothelial injury. Or microorganisms. Microorganisms also can directly lead to widespread endothelial injury, or they can lead to sepsis, and then the endothelial injury can be mediated by the TNF. And DIC is most commonly associated with obstetric complications, which we have already talked about. And triggers in these conditions, these obstetric complications are often multiple and interrelated. Okay, we can't just say that in this cause, this is only due to endothelial injury, or it is only due to sepsis, but there can be multiple and interrelated trigger conditions. And in bacterial infections, the endotoxins can directly inhibit the endothelial expression of the thrombomodulin. So whenever there is the inhibition of the thrombomodulin, directly or indirectly, then it can also activate factor 12, leading to formation of the thrombi. In formation of antigen-antibody complex, if it is formed in response to any infection, then it might also activate the classical complement pathway. It will activate the classical complement pathway, giving rise to formation of the complement fragments. And which will secondarily activate the platelets and the granulocytes. In case of massive trauma, extensive surgery, and severe burns, there will be the direct release of procoagulants such as tissue factor. And in obstetric complications, the procoagulant are derived from the placenta, dead retained fetus, or amniotic fluid, and they will enter the circulation and lead to activation of the secondary or the coagulation cascade. Okay. In hypoxia, acidosis, and state of shock, they can cause widespread endothelial injury and lead to formation of the thrombi, which we have already talked about. And if there is any supervening infection, they can further complicate the problem. And in any malignancies, like acute promyelocytic leukemia, we have talked about this, okay? adenocarcinoma of the lung, pancreas, colon, or the stomach. In cancers, they are most frequently associated with DIC, because these cancers with mucus, they might directly activate factor 10. Okay, they might, the mucus here, it may be the triggering factor. It will be a procoagulant and directly activate the factor 10. Now, after all these, there is now disseminated or widespread intravascular coagulation. Now, what are the possible consequences? There will be widespread deposition of the fibrin within the circulation, which will lead to ischemia of the more severely affected or more vulnerable organs. And there will be microangiopathic hemolytic anemia due to fragmentation of the red cells as they undergo extreme deformability. Okay, squeeze, as they are squeezed through the narrow microvasculature. And the second is consumption of the platelets and clotting factors and the activation of the plasminogen, leading to hemorrhagic diathesis. So one is the deposition of the fibrin and formation of the fibrin clot, leading to ischemia and infarction. Okay. Second is consumption of the platelet and the clotting factors and activation of the fibrinolysis, leading to hemorrhagic diathesis. This we have talked about the plasmin and the fibrin degradation products. Okay. So, in a nutshell, you should just remember that in pathogenesis of DIC, whatever you have to write about the cause. So whatever is the cause, initially there should be a activation of the coagulation. Initially there should be activation of the coagulation by either a release of the procoagulant or activation of the endothelial cell or injury to the endothelial cell. Then there comes the thrombotic phase, where there will be widespread or disseminated formation of the microthrombi. Then this microthrombi formation will lead to consumption of the platelets and the coagulation factors. And due to this consumption and secondary fibrinolysis, there will be hemorrhage. That's why we call DIC a thrombohemorrhagic disease, because the disease will be oscillating in between thrombosis and hemorrhage. And we do not know whether giving platelets to the patient or the coagulation factors will help or not, because they also might be helping for more thrombus formation. So this is the same thing again. You can see it yourself, which we have already discussed. Okay, tissue injury by either magneneoplasm, massive trauma, burns, surgery, or obstetrical complications. There will be release of tissue thromboplastin, or from sepsis also, by gram-negative or other infections, there will be release of the tissue thromboplastin, and there will be excuse me, activation of the extrinsic coagulation pathway, and intravascular coagulation will be there, and then there will be consumption of the clotting factors and platelets leading to bleeding. This we have already talked about, so I don't want to repeat it again. So you can go through it yourself. So clinical features: the onset may be fulminant, means acute, like in sepsis. Or amniotic fluid embolism, or not fulminant. Okay, this is not fulminant, but it can be insidious. Okay, in case of carcinomatosis or retention of a dead fetus, where the patient shows features or sign and symptoms very insidiously. The patient can present with dyspnea, cyanosis can be there, respiratory failure, convulsions, coma, oliguria, acute renal failure, sudden or progressive circulatory failure, and shock. So by looking at the laboratory parameters of all these, we can know which now has been the end organ damage due to the DIC. Okay, so you can see for the creatinine or the renal function test and see whether due to DIC the kidney is involved or not. If there is kidney involvement, then there will be oliguria, acute renal failure. Okay, if there is lung involvement, then there will be respiratory failure leading to cyanosis and dyspnea. And if CNS is involved, then there will be convulsions leading to coma, and there can be progressive circulatory failure and shock, and there can be microangiopathic hemolytic anemia. And laboratory diagnosis, the diagnosis is usually not only relied on the laboratory parameters, but usually on a combination of clinical and the laboratory features. And we know that there is consumption of the platelets and the coagulation factors. So both the platelets and the all the factors of the coagulation cascade are decreased. So bleeding time will also be prolonged, clotting time will also be prolonged, PT, APTT, and TT will all be prolonged. And in blood smear, we can see features of microangiopathic hemolytic anemia, and we can see the fragmented RBCs. And plasma fibrinogen levels are also reduced due to the consumption in the microvascular coagulation. And this, especially what we look for, is fibrin degradation products, okay, FDPs. This is also raised due to secondary fibrinolysis. And in morphology, now this is the morphology of the end organs. And thrombi are most often found in the brain, heart, lungs, kidneys, adrenals, spleen, and the liver. In the affected kidneys, there is presence of there will be presence of the small thrombi in the glomeruli. If it is localized, then there can be only reactive swelling of the endothelial cells or microinfarcts, or it can lead to bilateral renal cortical necrosis if the affected part of the kidney is larger. And in the lungs, fibrin thrombi will be present in the alveolar capillaries, and it will be sometimes associated with pulmonary edema and fibrin exudation. And if there is pulmonary edema and fibrin exudation, they can sometimes create a hyaline membrane, simulating similar to a ARDS. In the CNS, the fibrin thrombi may cause microinfarcts and will occasionally be complicated by simultaneous hemorrhage. And this will lead to variable signs and symptoms of convulsions, coma, and all these things. And in meningococcemia, there will be fibrin thrombi within the microcirculation of the adrenal cortex, leading to massive adrenal hemorrhages, which is seen in Waterhouse-Friderichsen syndrome. And there will be an unusual form of DIC in association with the giant hemangioma, also known as Kasabach-Merritt syndrome, where the thrombi will be formed within the neoplasm because of stasis and recurrent trauma to the fragile blood vessels. Okay, this is it for the bleeding disorders. Today we have finished DIC also. So any problem or any questions relating to this bleeding disorder, anything if you have, then we can discuss. Otherwise, it's okay. Any problem, let me know. Hope you have understood today's lecture. If you are silent, then I know that you have not understood.
Yes, sir.
Okay, that means you have understood.
Yes, sir.
Okay. Can you raise your hands? How many of you have understood today's lecture? Okay, 61, 62 of you. Then almost 30, 20, okay, 25 of you. Okay, now raise your hands who have not understood today's class. Raise your hands if you have not understood today's class. Okay. Okay, Apeksha Batrai,
Yes, sir.
you have any questions or you have any problem with today's class?
No, sir.
Okay. Okay. Pavalkar Rujuta, Ramesh,
Yes, sir.
you have any problem with today's class?
No, sir.
Okay. And Anulekha Mukherjee,
Yes, sir.
you have any problem?
No, sir.
Okay. Shivaditya Singh,
Yes, sir.
you have any problem?
No, sir.
Okay. If you are now given a question on DIC, then you can write it, right?
Yes, sir.
Okay, very good. Okay, then you don't have any problem with bleeding disorders. Okay, yesterday I couldn't upload the slides. Today I'll be uploading it right now. You go through it. Okay, I'll be uploading in the evening. Okay, not right now because I have to make the previous slide. Okay, then we'll meet tomorrow for the hematology practical.
Thank you, sir.
Okay,
Thank you, sir.
Thank you.
Thank you, sir.